as we are today opening the EU DiGA Con as part of our digital medicine conference. My name is Jörg Debatin. I have the pleasure to lead the Health Innovation Hub, and I'm very proud of the fact that we have this miracle come true this afternoon. Why is it a miracle? Because Germany was not necessarily known for being a leader in the digital transformation of healthcare, and it has transformed itself, at least in this aspect, into and catapulted itself into a leadership position. And we're delighted to have generated so much interest among our friends in Europe and beyond. And a very hearty welcome to everyone who is from outside of Germany and has come here to Berlin and is now watching sort of over the internet what we're about to present. I started this morning by introducing sort of a very special guest, the brain behind the digital transformation that we've seen over the last 4 years. And it is now my distinct pleasure to repeat this introduction. Gottfried Ludewig, who has been the head of the department, I'm not sure whether that's the right translation. Anyway, that part of the Federal Ministry of Health that is looking at innovation and digital transformation. And a very, very big welcome to Gottfried Ludewig. Now, I'm pretty sure, Gottfried, when you started in this job, you would have never thought that we would be in this position, in a leadership position of any sort when it comes to digital aspects, particularly digital medicine. I certainly wouldn't have. And just as a reminder, and I already mentioned that this morning, we had that study from the Bertelsmann Foundation that pegged Germany out of 17 evaluated countries with regard to their digital maturity in the healthcare systems. They pegged us at number 16. Only Poland was doing more poorly than we did, and now we are here celebrating, in a way, the fast track of DiGA, which really encompasses a lot of very un-German new territory. We actually are trying out stuff without knowing without waiting for perfection, which is indeed a little bit un-German. But it is a major accomplishment, and you're really the guy who made it possible. So tell us a little bit about the journey, and then we'll sort of look what we can do from here on.
Okay, so well, first of all, thank you very much for having me. I couldn't agree more on everything you said already. I'm actually still very amazed that we made it, and that the DiGAs really were set in place and at a very high speed, to be very honest. I think it took us something like 1.5 years, 2 years, from starting the process to having the first application really prescribed in the German system. And I think everyone who knows the German system knows that this is not the typical speed we are moving forward normally. But however, I think it's just it's a real accomplishment of the whole team, and you will meet and listen to our experts from the BfArM, our experts from the Federal Ministry of Health. Tomorrow also our Minister of Health will be here, because without Jens Spahn, to be very honest, nothing of that would be possible, because you need a real leader, you need someone who pushes that forward. But the basic idea, so to come back to your question, the basic idea was, actually, there is a digital market of digital health applications, and the German healthcare system actually does not care, right? There is no one who cares about that. We know that there are health applications. We know that people buy health applications. They pay for it, actually. But the system is like, oh, what should we care? And I was the one, actually, with the minister and others who were like, well, this is our basic job description, to care about things who create maybe a better outcome in healthcare, who have an impact on healthcare. And this was how the whole story actually started. And with this basic idea, we moved forward with the wonderful team at the Federal Ministry of Health. And we really did something very un-German. We just tried it. And I think that's the basic message of everything we did here, is like, give it a try. Then see what happens, then in an agile way, make it better. And I'm very, very honored and blessed, and I look to Henrik, who will be leading probably this kind of session. If we see the participating European Union countries, and some of us maybe already saw President Macron something like 4 weeks ago, who said we will copy the German model of app prescription, or of this reimbursement scheme. This was something I never imagined before, that the French president would one day say something like, we will copy the German model. So
I'm sure he won't say that again. But
yeah,
anyway,
yeah.
You've been kind, and in the community, a lot of the community credits us, the Health Innovation Hub, with providing all the good insights and the great ideas that you then have implemented. In this case, I'll share a secret with you. It was none of that. I remember distinctly, we just created the Health Innovation Hub. In one of our first meetings, I saw a beaming, very happy Gottfried Ludewig approach us in this. We are sort of in a typical Berlin environment. It's garbage cans and stuff like that around. Anyway, he came. He passed through the garbage cans. He was beaming, and he said, "We've got the DiGA-Fast-Track," and I was really impressed by the boldness, by the courage, by the commitment to let's try to get experience in a safe environment, because that's also part of the truth. We are all very aware of the very special responsibility we have in the healthcare system to keep it safe, to not expose patients to undue risk. So it was very clear that these were going to be applications that went through a very thorough evaluation process, that they needed to be CE mark, that they went through a subsequent evaluation process with BfArM, and then would be limited to MDR stage 1 and stage 2A. I remember the very first session we already sort of started saying, hey, we got to go for 2B and 3, but it was the right decision to start with this and to get experience and then build on that. I will say you were lucky insofar as this idea fell on very fertile grounds. And the most important ingredient to this fertility is really many of you, the producers of apps, the creativity which we found in Germany, not only in Berlin, but in Germany and beyond, is really impressive. And I think we owe it to our patients, but we also owe it to them to have their ideas come true. And that's really what this DiGA-Fast-Track did. And it allowed people to get this experience. So one ingredient was the creativity of the DiGA producers. The other ingredient is a lot of people, and I see the colleagues from BfArM sitting in front of us. Without the two of you, and it is really very personal, the two of you, much of this would not have happened. So thank you very much for that. And I will say a lot of other people have contributed also. So it was really that mix of personal conviction and motivation and creativity and courage. And now we can actually celebrate the EU DiGA Con. And
which is, if I might add that, just a second,
no,
because it's really, I mean, thank you for the compliments for the Federal Ministry of Health, but I want to pass on the compliment again to the Health Innovation Hub, obviously to the chairman always, but also especially this time to Henrik, who will join us here on stage, because he took it from there and he said, okay, this is something we are doing on a national level, but he pushed it forward to bring it also on a European level. And this is a really big achievement, because I think Europe has an enormous, a tremendous chance in this process to really once, probably in the European lifetime, to really be a front runner in digital health and to become a really innovative market here and really become competitive also regarding the US, China or Israel. And if I may say so, also a big round of applause for Henrik for pushing that forward, and to the wonderful team of the Health Innovation Hub. Thank you so much.
Okay, Henrik, now time to get to work.
Yeah.
And while this morning I sort of said, you got to share sort of the applause with Natalia and
right.
Many of the team. This session is really all yours. Without you being the motor, as you pointed out, none of this would have come to fruition. So thank you very much for that, and now all yours.
Thank you. Thank you very much. I was very much looking forward to execute this session. You know that the HIH is dissolving in about 6 weeks. So this is our last big stage that we have, and I wanted to make it a special one. And all the credits first go to the Federal Ministry of Health and BfArM, who created and implemented this fast track. Without them, we wouldn't be here. And that's obviously a lot still to do. We are not even halfway to a journey where our healthcare system would be digitized and healthcare professionals and patients would work hand in hand with their digital enabled data and all of that. But, and this is very important, and I learned this tremendously in the past 2.5 years, you need to start somewhere. You cannot continue discussing a perfect world while everything else is changing. You need to start, learn, adapt. As Gottfried Ludewig was just pointing out, we have been in a sort of agile lawmaking in the past 2 or 3 years by the Federal Ministry of Health, which is very much unknown to Germany. Normally we try to go for the perfect solution and it takes us 10 years and then we realize, oh, the world has changed in the meantime. But in this case, we are really in a fast-pacing environment and trying to catch up and trying to pioneer. And this is my personal motivation why I wanted to have this event happening today. And Gottfried already pointed that out. We are in a pioneering position. And if we don't screw it up this time, and we did screw it up a lot of times in the past decades, we can still lead this digital transformation in healthcare in our understanding, our European values, our laws. And it will not be a situation where in the near future there will be American hyperscalers or Chinese tech companies defining how digitization in that special area in healthcare is happening. It can be on us. And this is why I'm super happy to have, after the session now where we're going to explain the DiGA-Fast-Track to all of you, especially we have probably 1,000 people in the live stream from all parts of Europe, but also beyond, where the colleagues from BfArM, Wolfgang Lauer, Wiebke, Löbker will explain DiGA-Fast-Track. After that, we have the panel where we discuss with other European nations to what extent we can harmonize regulation on digital health. So, for now, first half of this conference is for you all to understand in greater detail the DiGA-Fast-Track, also to post all your questions. We have an Ask Me Anything session with Wiebke Löbker from BfArM, Lars Hunze from the Federal Ministry of Health, and myself. So if you are watching us live via the live stream, you already see Slido on the left-hand side, and you can already start now to put in your questions and upvote them so that we know which questions are most relevant for you. All the questions will be answered from 20 to 3 onwards. And after the break, we then open the horizon to the European level. And I'm very grateful that so many European representatives are either here in Berlin, later on stage, or following us on the live stream, and then will join us remotely from their capitals. So, first, we start with the groundwork. What is the DiGA-Fast-Track all about? How does it work? How is the process working? And equally important, because it's now 12 months after we started this adventure, what are the learnings? And in which areas can we still improve? And where are we in terms of digitization of that space? And I'm happy to have Wiebke Löbker and Wolfgang Lauer here with me, who are really essential in implementing the DiGA-Fast-Track. And I will leave now the stage to the two of you so that you can explain the DiGA-Fast-Track process and give an outlook of all the learnings that you had already by now. Thank you very much for joining us, Wiebke Löbker and Wolfgang Lauer.
Thank you very much, Henrik. Thank you very much, Prof. Ludewig, Jörg, Debatin, for the kind introductory words. It is really, do I have to change anything? Or can you hear me? Yes, I have a mic. Do I have to turn it on? On? Should be, well, let's try this on-off switch. Maybe it changes something. Okay. So again, now it's much better. So on-off mentioned something. So thank you again for the kind introductory words. And my colleague Wiebke Löbker and me, we are very happy to be here and to explain a little bit on the DiGA-Fast-Track procedure for those who are not yet that familiar with it, and to share some experiences with about 1 year DiGA listing, DiGA registry, with all of you who maybe contributed or are interested in this area. So let's start a little bit with just a short look on what the BfArM is, because maybe some of you are not familiar with what we do, where we are located, or what are our main tasks. So, as the name says, Federal Institute for Drugs and Medical Devices, so a big part of the institute, of course, is working in the field of medicines, licensing, risk detection for medical medicines, and also for medical devices, and all the questions about clinical trials, and a lot of, let me say, a little bit classical things that we work on. However, since several years already, BfArM has changed a lot of its work and has enriched the work and has become, I think, a central player for Germany and also for the European context with regard to digitization, in terms of, for example, classifications, terminologies, any kinds of standards, information systems, databases that we deal with. So a lot of digitization that with relationship to drugs, medical devices, but for health in general. And so when we think about our role here and our role of the digital health applications of drugs, of devices in the future, we see them as one part of the digital, mainly digital, but also, of course, traditional infrastructure for healthcare in Germany and also in the European health area. Because then, if you look at this overview, we have DiGA as one part. We have, of course, the real-world data aspect that we have been talking a lot this morning. We have digital European data spaces. We have digital nursing applications in the future, and a lot of other things. And we see BfArM really as one of the core players in this digital evolving health system in Germany. And the decision of the Federal Ministry for Health, which we are very, very thankful for, to choose BfArM as the institution for doing assessment of digital health applications, was of course based on a history we have in this area. Already several years ago, we started dealing with digital applications from the viewpoint, for example, of medical devices. So digital medical apps were one keyword that we dealt with. Then we had a lot of dialogue conferences in terms of medical apps where we talked about the need of patients, where we talked about all the getting on the market processes, but where we also already talked about reimbursement aspects. Because, of course, we think that if you want to do something good for patients, you need to have a financing model based on that. You need to have market access. You need to provide safety, but also you have to refinance your investment on the market. So this is an important step too. We continued that in 2017 with the foundation of our innovation office that is headed by my colleague Wiebke Löbker, because we wanted to support innovation. We wanted to provide safety and to support innovation at the same time, and therefore we give advice to innovators, to startups, to university research groups, for example. And in this context, as you can see here, we also dealt with a lot of other aspects with regard to digitization in healthcare. Cybersecurity is an increasing and very important topic because we see a lot of medical devices which are parts of networks. So cybersecurity issues are a very, very important topic. And what was very fascinating for us, because it was talked about this very agile lawmaking process that we had in terms of the DiGA pathway. And we were very happy to join the roadshow that was organized by the Health Innovation Hub together with the Federal Ministry for Health. And this was a very, very impressive tour we had with a lot of discussions, also getting impressions, getting views, getting standpoints that we could include in our assessment procedure. So it was also mentioned by Gottfried Ludewig that it was really a fast track already from the beginning or before starting the assessment procedure. A fast track from the Digital Health Act to the ordinance later on, to bringing that into, let me say, more practical life with our guidance documents, for example. Then in May last year, we opened the application forms for DiGA assessment. And only about 1 year later, after the Digital Health Act, the first DiGA were listed in our directory, and that was the start of the directory in October. So it was a very much agile and also learning process, and we are a little bit proud of it and still learning for further developing this process. But first of all, of course, for you who are mainly maybe English speaking, what is DiGA? It's maybe a kind of weird acronym. It's of course for the acronym for Digitale Gesundheitsanwendungen, German abbreviation, and it's about digital health applications. And what are digital health applications in this context? First of all, and that's the important point, to secure all aspects that are related to medical devices and bringing them onto the market, they have to be medical devices already CE marked, and they have to belong to the lowest to risk classes 1 or 2A. It was just mentioned as a starting point. We'll see what the future brings, but right now it's already at 1 or 2A, because that's a good field to get experience, I think. Then it's about digital aspects, of course. It's not about just supporting human medical doctors' action, but it's really about the digital impact that is used for diagnostics, that is used for therapy. And the DiGA has to support all the health-related aspects, like, for example, monitoring, treatment, alleviation of diseases, injuries, or disabilities. What is the characteristics of a medical device? What is also important is that DiGA are tools in the hand of patients. So they are not a radiology system that is just used by professionals. They are really tools that are maybe used on a mobile phone, that are used on a computer, web-based tools, but they are to be used by patients in their own surroundings, in their own hands. So that was an important step forward to really define this class of products. And then they have to fulfill a series of requirements, which include, for example, based on the CE marking, and most of them included in the CE marking for medical devices, safety and performance. They have to be safe, they have to perform what the manufacturer claims, of course. Then, very important for these digital applications are data protection and information security. So these were aspects that are in some parts addressed by the CE marking for medical devices, in some not. So they were included especially in this DiGA assessment procedure. And of course, most important of all, from my point of view, they have to bring positive healthcare effects. They have to bring patients forward. They have to bring our healthcare system forward. And what is really a huge innovation from my point of view is that these positive healthcare effects are based on, let me say, 2 pillars. And the DiGA can choose either parts of one pillar or both or part of the other. So the one pillar of healthcare effects is the medical benefit, classical medical benefit, survival, reduction of diseases, morbidity, mortality, quality of life. So let me say classical medical benefit aspects. And the other pillar are aspects that support the healthcare system. So they support the healthcare or the health behavior of patients. They support the healthcare system. They support, for example, how patients with chronic diseases can deal with their everyday life. How can their relatives support them? All these aspects. And you can see here that there are a lot of aspects which are not covered by, let me say, classical medical benefit, but are very, very innovative for this kind of process and also for being considered for reimbursement. And this is a really innovative step and a really fascinating step. So you can see here health literacy, patient safety, also facilitating access to care in regions that are maybe where the number of doctors, nurses is lower than other regions. They can be used to really grant access to care. I think most of you may already be familiar with this DiGA-Fast-Track procedure. Just a really short overview. So the procedure for an assessment at BfArM starts with the manufacturer and his or her application. And then we check in the assessment these two kinds of requirements, safety, performance, data protection, let me say a little bit more technical aspects, for example, and on the other hand, these positive care effects that I just explained. For this assessment, 3 months are the maximum time we at BfArM have. And this is a hard time frame, so there are no clock stop possibilities. So within these 3 months, with all questions back and forth, with all things that have to be answered by the applicants, 3 months is the time frame. And maybe those of you who are already have run through this assessment procedure know that this is, well, a challenging process, not just for us as assessors, but also for you as applicants who have to answer maybe questions within a short time frame with an eye on these 3 months. If everything is okay, then the DiGA is directly listed, permanently listed in the registry of DiGA. And BfArM also determines some medical services that are directly linked to the application of the DiGA. If the requirements are fulfilled, like safety and performance, and there are preliminary hints for a positive evidence in the end, but not all evidence is on the table right now, then, and that's also a very innovative step, there is a preliminary listing in the DiGA directory for 12 months where already reimbursement is granted on the complete German market, but this time can be used to generate additional evidence to prove everything you need in the end of these 12 months. So in the end, there's the final decision, yes or no, permanent listing or out of the list, yes. Besides that, there's the process of price negotiations with the statutory healthcare system providers. So BfArM is not involved in that, but this is also something that could be a longer talk in this area, but the price negotiations are very interesting, of course. So, as I said, we had the Health Act, we had the ordinance, and there, from our point of view, and especially also from the ministry's point of view, there was still a gap between, let me say, the legislative wording and understanding and the practical everyday life. So there was a bit of translation needed, there was additional information needed, examples were needed. And based on that, we wrote a very comprehensive 140-page DiGA guide and published it in German and also in English on our website for manufacturers, patients, service providers, medical professionals, where really everything is laid down. What is a DiGA? What does it have to fulfill? What can you rely on when you find one? When you have a prescription for a DiGA, how can you get it? How can you prescribe it? What evidence is proven? And so on and so on. And this is published on our website, and you can find everything there. It's a living document. It's regularly updated to really have a lot of examples inside and actual decisions, for example. So the examples are here to really explain what can be a DiGA. Mobile application, browser application, for example, but also to explain what is not a DiGA, because the requirements that I mentioned in the beginning are not fulfilled. And what is a DiGA? To really give you fruitful examples to help you understand with your product whether it could fall under the DiGA regulation or not. We also have a lot of up-to-date information and explanation on our website. You can find all the data with regard to, for example, numbers of applications, DiGAs listed in directory, literature, for example, actual decisions on data protection issues, all of that on our website. And we also have a lot of detailed question and answer parts within the DiGA guide in German and in English, as I explained. For example, here on the pharmaceutical central number, that's the carrier for the prescription in Germany. We also thought that we should develop our information formats and bring them more to you as the community who is at home in this digital area. Because sometimes, of course, we had a lot of discussions in the beginning. Well, it's a long-standing institution dealing with drugs and medical devices. And now we're entering a very, very agile community where there's the discussion format, the contacts, all these aspects are a little bit different. So we developed also at BfArM, or we think we developed our communication and our availability, our talks, our contact with you. And this blog we started some time ago is another approach to give you some more insight. Which people are working here? How do they take decisions? How are the learnings on DiGA, an example, just currently? What can you obey as an applicant for DiGA? What have we learned from 1 year DiGA directory, for example? So there are a lot of things, and I just recommend to read our blog because there will be a lot of information all around medicines, medical devices, and DiGA also in the future. And of course, our innovation office is one core player and one core contact point for all of you who want to have more information on DiGA, who would like to discuss things with us in advance to filing an application for a DiGA assessment procedure, for example. And we just recently published in the Bundesgesundheitsblatt, unfortunately in German, but I think it's easy to translate, and it's also open access in a lot of parts of it. Our experience from, for example, DiGA processes and other aspects that we provided. So these are a lot of things that we put forward to bring DiGA much more to you, much more to patients, to medical professionals. And of course, you can find a lot more information on our website, on the DiGA directory, and within the DiGA directory. Because with now 24 DiGA in the directory, one after the other also implemented a lot of search or filtering functions. We implemented searches for example, keywords, for ICD codes, so that you can really, if you're a patient, find what DiGA could be suitable for you. You can, if you're a medical professional, find out what evidence was the basis for our decision, what was proven before the decision, and what can you rely on when you do prescriptions. So our recommendation is really to have a look at our websites and send us a lot of input if you want to have further information or have some comments. Having said this, I would like to hand over to my colleague, Wiebke Löbker, for explaining experiences we have gathered in this past year. Thank you.
Thank you, Wolfgang. So more than one DiGA-Fast-Track. Where are we now? By Friday, we received 100 applications so far, and currently there are 21 applications in the evaluation procedure, but as Wolfgang already said, 24 DiGAs successfully passed the DiGA-Fast-Track procedure and have shown sufficient positive healthcare effects and fulfilled all the other requirements. Currently, 6 digital health applications are listed already permanently in the DiGA directory, and 18 DiGAs are listed preliminary. So there's coming now, or they are now in the evaluation phase to show that they really do have positive healthcare effects. On the other hand, we see that 5 applications were rejected and around about 50 applications were withdrawn by the manufacturers. I will tell you later on what were the reasons for this. But so far, where are the applications coming from? As you can see here, mainly from Germany. But we are in a European setting or international setting today and tomorrow, so we also see applications also from other European countries, and 85 applications from the hundreds are from Germany, but we see more and more applications for advice procedures coming also from other European countries and also from the US or from New Zealand, for example. What kind of therapeutic or diagnostic approaches do we currently see within the DiGA applications? So the majority is addressing cognitive, therapeutical or behavioral therapeutic aspects, and we also see some kind of exercise therapies, for example, for treating pain or migraine attacks, to help people to handle their disease, to learn what kind of signals they will face and how to act against this, for example. We also see some kind of aftercare settings, for example, during or after an oncology cancer treatment, and a lot of other approaches, sharing knowledge or helping to be some kind of documentation like a diary in diabetes treatment or migraine treatment, for example. But also DiGA that are helping to monitor disease and to teach some kind of training programs or that have gamification aspects. What kind of DiGA do we see? The main are native apps, but we also see web applications and some combination products, for example, that are used via app in combination with an app application or both. And we also have 2 DiGAs listed using a virtual reality glasses, for example, in combination. Wolfgang already said that DiGA are mainly used by the patient, so they are digital supporters in the hand of the patient, but a lot of DiGAs are also accompanied by physician treatment, for example, or some kind of help that is provided by the medical doctor in the background, for example, allowing patient to move to the next training level, for example. And we also see a lot of DiGA that are working together with hardware, for example, like blood sugar sensors or others. I already mentioned it. We see some withdrawn of the applications and also some rejections. So what are the main reasons for it? I think we can separate in applications for the permanent listing and also for the preliminary listing. But beside the positive healthcare effect evidence level, there are also other reasons, for example, that data protection or data safety aspects were not really fulfilled, or the requirements were not really fulfilled. Or that documents or relevant information were missing in the application documents. And for example, we had 1 or 2 cases where there was no comparison against a comparator, but that is what the ordinance requires, that there is also a comparison compared to a standard of treatment, for example, or to another DiGA that might once be listed in the DiGA directory. But this were data without any comparison. But for example, with regard to applications for a permanent listing, study protocol or pre-specification of endpoint evaluation was missing, or the study has considerable limitations or does not show confirmatory evidence. In this case, it is possible that the applicant withdraws the application and can submit later on, for example, for a preliminary listing, if we consider that these data are not really sufficient so far for a permanent listing, but for example, for a preliminary listing. And with regard to the applications that we received for a preliminary listing, often the systematic data evaluation that is required was not really helpful because, for example, the evaluation period was too short. Of course, we do not ask for a complete evaluation period. We ask for a permanent listing in a diabetes care setting, for example. But we need to see that there is some kind of effect also in a shorter period time frame. Or the evaluation was not carried out with the DiGA that is subject to the application process because it was some kind of prototype, for example. So this is not acceptable too. With regard to the evidence level, I think we will go into detail in the evidence con tomorrow, but to highlight just a few aspects, more than, or the majority, more than 80% submitted randomized controlled trials to show that there is a positive care effect for the DiGA. And mainly in addition, we also see some kind of other evidence, for example, questionnaires that were used, or in the majority, intra-individual comparisons, so showing the positive care effect before the DiGA was used compared to a period of time with the DiGA. When we look at the DiGA that are currently listed in the directory, we see that, I already mentioned it, the majority is listed preliminary, and that the main or majority shows a medical benefit. Wolfgang said there are two pillars, the medical benefit on the other side and or the improvement in structural or procedural aspects, but currently the medical benefit is predominant. And yeah, we already mentioned it, the evidence is mainly based on randomized controlled trials, and yeah, so that's the fact for the DiGA currently listed. When looking into the future, when we look at the DiGA consultations or our advice procedures, we see a stable number of requests for advice by the BfArM and a decrease in the, well, we said some kind of requests or simple questions addressed to the BfArM. This can be explained, or is a good proof that our supporting information and documents on the website, like the DiGA guide and the tips and tricks, for example, on the website, that they are really being helpful for the manufacturers and can answer a lot of questions in advance. But with regard to the DiGA consultations, we also see a very broad range of indications, more than we currently see by the DiGAs already listed in the directory, and also, as I already mentioned, applications from around the world. What are the main discussion points in our consultations and talks we have beside these procedures? Is, of course, the DiGA compliance. So is it really a main digital function, for example? And I think one of the most important points right now is the evidence. Is the evidence that is already available, or is a study that is planned, is it really helpful to show that there's a positive healthcare effect, for example? Have they chosen the right endpoints to show or to prove the positive care effects? And the other important aspect beside the endpoints is, of course, the comparator. So, for example, is a pre-post comparison or an intra-individual comparison, is it sufficient, or is, for example, a randomized controlled trial needed here? And maybe just to give a hint here, we cannot say black or white here. It always depends on the indication that is, or the DiGA is used for example, to reduce the blood pressure or helping to handle blood pressure, for example. There's a high placebo effect, for example, so we cannot say, okay, a pre-post comparison will always work in this kind of situation. And maybe you already joined the sessions in the morning, but what we also see is that interoperability is more and more important. So positive healthcare effect is one important aspect of the DiGA, but beside data protection, data security, interoperability will be more and more important. So it is important that the DiGA is not only working together with hardware, for example, but also that in the future the DiGA can interact, or that data can be transported, for example, to the electronic health record. So there are a lot of requirements already available that need to be fulfilled for a DiGA to be listed, but there will be more requirements in the future to ensure that these data transfer is really possible and that we will have an interconnected e-health system. So starting to summarize more than one DiGA, I think we already heard from Gottfried Ludewig. I think the best compliment and the easiest way to summarize it is the announcement by President Macron to say we will adopt this successful system one-to-one in France. But to go a little bit more into detail, what we see is a high public interest in the DiGA-Fast-Track, not only in Germany, but throughout Europe and also other countries. We already heard that it was really a fast implementation, so it's not only a fast-track procedure, but it was really a fast-track implementation of this new procedure in Germany. With more than 100 applications, we consider it a really successful start of this fast-track procedure here in Germany. And we also see that the comprehensive support for the manufacturers we are offering, like we said, we started with a roadshow before the act came into force to inform about the procedure and what is possible. We have the DiGA guide, we have a lot of information, we have our advice procedures, etc. That the close exchange with all stakeholders, not only with the manufacturers, but also with the medical doctors, with the health insurances, etc., is really, really helpful to better understand what is needed and how we can improve our support activities and to make the DiGA-Fast-Track, or the DiGA mainly, an important piece in the puzzle of the electronic health infrastructure here in Germany. As I already said, interoperability, data protection, data safety are more and more important. So we already heard that the next improvements, for example, will come soon. And this will not only be the transformation from the digital health applications, also including in the future the digital care applications, but that there will also be certificates addressing data security, data information aspects instead of the confirmation by the manufacturer. So it's a step-by-step implementation of this procedure, but we think the start was very successful. And if there are any further questions, I think we will now have the time for it. But please feel free to have a look at our website and to contact us for any further questions.
Wiebke Löbker and Wolfgang Lauer, and we will continue now with Wiebke and Lars Hunze. Lars Hunze is also another essential figure of the DiGA-Fast-Track, because without his night and weekend shifts, we would never have this law even in a concept or draft stage. And now he joins us on stage, and please have a seat. We will now go to your questions. And there were already some questions on Slido, but you all in the room are also free to ask questions. We have one lady with a mic. Constance is over there. So if there are already first questions, please just raise your hand and you will be given the mic. Otherwise, we will start with the questions from Slido, which Philip, my colleague, just wrote me here. First question is, the market entry barrier for MDR software is remarkably higher than MDD. Can the DiGA process from Germany be copied to other countries, or was it the combination of the MDD and the DGV that fostered startups? Maybe that is a question for you.
Well, it pretty much depends. I mean, the situation will probably be comparable in other countries. There are a lot of products which are still on the market that have an MDD authorization and benefit of the prolonged and extended transition period. So the situation is comparable. What we will certainly do is to evaluate the effect of the entry into force of the medical device regulation, and if there's a need to adjust or to adapt the risk classes, that's something we will certainly consider. As we've already mentioned, yeah, that's a learning system, and that is one effect, and products that have been considered to be safe and patients benefit of those products. I think nobody would say, well, now the law, the European regulation changed, and we'll take that away from you. So yeah, that's something we have to monitor, and basically that applies to everyone alike, yeah.
Thank you. And you already touched the topic that is often asked and also today has the highest votes. That is the question on when will there be a fast track for 2B and higher risk classes?
Well, at the moment we are a bit in a hiatus. We'll see what the next government is up to. Of course, we don't stop thinking. We'll see if somebody likes our ideas.
For all the non-German viewers, we just had federal elections, and there will be a new government be formed out of 3 parties. 2 of those have not been in government before the current one, so there will be new cards on the table, probably also to that regard. But, and that is something that I also want to highlight, all parties that are now about to form a government had been very positive about the digital transformation and want to continue that digital transformation. So we will have a continuation of that transformation process, no matter who of those parties will then lead the Ministry of Health. That is at least my personal understanding of all of their public comments. Now, a question to BfArM, which I don't know if you can answer it. How many staff are working to run the DiGA directory, i.e. evaluate applications by companies, ensure adequate criteria, liaise with companies, etc.? And second question then, have the criteria been adapted since the start of the directory?
So I had difficulties to understand the first part of the question, but first answering the second part, no, that's one important aspect in this procedure, to guarantee that we assess it in the same way. So the criteria have not adapted so far. Of course, we are learning how to transport our learnings to the people. And for example, as Wolfgang already mentioned, the DiGA guide is a living document. So if we think, oh, this is a good example to explain it in a better way, for example, then this example will be added to the DiGA guide. But our assessment criteria are the same from the beginning. So there's continuity is important here.
Right. And maybe what has changed is the DiGA V. I don't even know what this is in English, but maybe you can elaborate quickly on the alterations of that.
Yeah. So I think what Henrik is referring to is the Digital Health Application Ordinance. That is the implementing legislation that somehow gives further information and details on the piece of legislation that has been passed by Parliament. Of course, the implementing legislation has changed. It changed because of it changed to incorporate new certificates for data protection and data security, which will be available in 2023. So there's a transitional period that has been that is in these that can be found in these documents, but these documents have already been amended. There are new requirements for interoperability. As you may have heard, we started our national e-health record, patient-centered personal e-health record at the beginning of this year, and DiGAs are meant to export data that is relevant for the treatment of the individual patient in the patient record. And so we've amended the Health Application Ordinance with regard to technical aspects that are required for this export of data. So yeah, the Health Application Ordinance certainly is a living document, and somehow reflects also our commitment to somewhat foster the integration, the technical integration, but also the procedural integration into day-to-day care.
Right. And the first part of the question was how many people work at BfArM on the DiGA directory and on the various parts of the DiGA-Fast-Track?
Well, it's not so easy to answer this question because we have people at different units and departments at the BfArM supporting the evaluation processes. But for example, once the law came into force, we have implemented a DiGA-Fast-Track unit at the BfArM, and currently 7 people are working there, but they are supported, for example, regarding the advice procedures from the Innovation Office. We have our lawyers supporting if there are legal questions, for example, and also our colleagues who are familiar with the data security, data information aspects, and also our colleagues from the licensing departments who are well-experienced medical doctors, for example, who can help with the medical aspects in addition. So I think we cannot say so many people are working on one concrete dossier, but it's work sharing at the BfArM.
And that is probably also interesting for the second half of this afternoon, where we discuss how other European countries may adapt a similar concept of the DiGA-Fast-Track, also to understand how much domain expertise you need to have in your teams who then regulate the entire process. It's not just done by 1-2 people screening applications, but you really need to have a team of diverse experts who then look at all of the entire process.
Yes. So when, for example, looking at the DiGA already listed in the directory, we see some kind of cluster currently. But in the future, there will be, or now coming up, more and more diseases. So to say, to have experts in this concrete unit who are able to cover all these indications, I think this will not be really effective in this way. So it's easy to say, okay, so now it's DiGA, for example, treating pain, then we can ask our experts in the licensing department, or if it's diabetes, we can ask other colleagues to really become the expertise that is needed here.
Perfect. Do we have questions in the audience already? Jochen is raising his hand, and there's another 2-3 questions. So Constanza, if you could support us with the mic.
Here.
Perfect,
Yeah.
there we start.
The first question was...
Perfect, thank you.
Hey. Otherwise,
And
I
please
can just...
quickly say your name and also
Does it work?
your background, if you
Hello?
are from the startup world or from...
Yeah? Okay. Yeah, so my question would be, do you know how many DiGAs have been prescribed so far? And if not, what would be the main reasons for that?
So we know that roughly 50,000 plus have been prescribed since 12 months. That is slightly below our expectations, but to be honest, we are also in the midst of a global pandemic, and there were other topics more pressing in outpatient care than DiGA. But still, what we learned from that is that the education and the commitment of the physicians and doctors are very important, and you need to think that through, and you need to get their buy-in as soon as you implement that in a country. So if we are now talking to our French colleagues, that is some of the recommendations and some of the learnings that we would give them. We very much focused on implementing all of that, informing the various stakeholders, but the doctors need to start educating their own peers and have conferences and know-how exchange and best practice and key opinion leaders and all of that in order to make this from the start already a success. We are starting step by step, and the DiGA manufacturers are now much more active in educating their scientific societies and communities on the doctor side, on the medical side, but that's something that is still a strong learning that we would also give to other countries.
But do you work together with the insurances to get the data on how many DiGAs have been prescribed, or how, like, do you track how many DiGAs have been prescribed so far?
Yeah. That is basically what the health insurance funds do. They track how many DiGAs have been granted on application, how many DiGAs have been prescribed. and there will be a structured, there will be an annual report presented to Parliament each year, starting at the end of this year. So we will we are most likely going to have the first structured report on the very last day of this year. However, as we've just started, and as the law that creates the obligation to draft this report has been passed in June, July, we will see that the report will contain some basic information this year and will be far more detailed next year, as the health insurance funds will certainly collect more detailed information in the years to come.
Okay, thank you.
And then there were more questions over here.
Yeah. Hi, my name is Jonas. I'm the Chief Commercial Officer of a Danish startup called Liva Healthcare. Perhaps we'll go more into detail with this tomorrow at the Evidence Con, but I have a question relating to the evidence needed for the DiGA registry. I've, of course, studied much of the material available, but if I were to add 2 and 2 together with what you just shown here today, Wiebke, you pretty much need a German RCT to get into the registry. Is there thoughts about narrowing down the possibilities within the DiGA framework for submitting evidence, where today it actually states quite a broad wealth of evidence? You can even use real-world evidence for your application. But is it pointing more towards that in the future you should do an RCT?
I had difficulties to understand you because the sound is not very good on stage, and it was.
I apologize. I'll try again more simply. Is it needed to do a German RCT?
If an RCT is needed to be submitted, or what was it? It's really hard to understand your question, sorry.
I'll just try to walk closer. So the basic question is it needed to do a German RCT?
Okay.
Because basically, if you look at the numbers you showed on the slide, 85% of the companies applying are German. 24 out of 25 have an RCT evidence. So it leads me to think the writing on the wall is you need a German RCT.
So the question is not really yes and not really no, but the DiGA says that a comparative trial is needed, and for example that an individual comparison might be sufficient. But it really depends on the current situation. So what kind of disease it is the DiGA is used for. And so it's not easy to say yes, really yes or no. But we do not really ask for an RCT if another study type might be also possible to show that there's a positive healthcare effect. For example, if you want to show some kind of adherence, an RCT is not really required. But what we see that the majority of the DiGA so far has a medical benefit as a positive care effect. And in the majority there, it is easier to do a short or small randomized control trial instead of big statistical calculations beside. So they have chosen on their own to do a randomized control trial, or they already have done in the past before it was clear that there will once be the DiGA-Fast-Track. And I think there's another aspect in your question, if it needs to be a German RCT. No, it needs to be comparable to the German standard of care setting, but we would also accept trials from other countries if it is really comparable, because they are same the treatment baselines, for example, in both countries.
Thank you. And then there were more questions on this side.
Hello. I'm Moritz. Hello. I have one question regarding the also regarding the RCTs. Did one of the non-RCT applications come through so far?
Yes.
Okay. That's it already. And maybe a second question, like if you would be the next Minister of Health, what would you change maybe on the process? Is there something that you would immediately change, if you could, to both of you?
So I'm 100% sure that I will not be the next Minister of Health in Germany. But no, I think the first improvements are underway, or the next steps, like the care apps. So I think from my side, there's nothing I would do just right now. I think we heard today it's a learning system, and yes, I think there will be some improvements and some further developments in the future, but not so urgent at the time being.
I mean, probably the phrase "never change a running system" is something we hear far too often in this country, but I would certainly say, well, it works. Let's see where it leads us.
Maybe something that I'm also not becoming the next minister, but I also want to add on this. First, we need more resources also on the side of BfArM to make sure that this process is running smoothly, exactly with the additional topics like DIPA and so on. And this is something BfArM is not going to say in public, but I can, because we are dissolving in 6 weeks. So they need to make sure that an institution like BfArM has all the resources for all the current but also upcoming topics, and that's challenging in the TVÖD environment. And second, and that's some of the learnings that I just shared, we need to get not a larger buy-in from the doctors as such, but there needs to be an institution that is taking care that the doctors and physicians fully understand their opportunities and educate the entirety of the German doctors, and also have just a know-how transfer, which is at the moment not happening. And that's frustrating, because there are so many digital initiatives happening in Germany. At the moment, we just had the morning sessions on all those innovations, and we don't know yet, because no one is really taking care of that, how to educate all the doctors that we have in outpatient care, especially about these new opportunities. So that's something that we really need to work on.
Yeah, my name is Ingo Horak. I'm digital health entrepreneur and consultant. And I have a question in regards to the regulatory roadmap. So we have a great framework for DiGAs and DPAs to come. And we all know about the relevance and importance of prevention. So when will preventive application follow?
Okay. That is quite an interesting question, because they don't necessarily need to follow in our footsteps, because there is a different procedure. There is the so-called Zentrale Prüfstelle Prävention, which is an institution that is also granting access or also deciding upon the reimbursability of preventive institutions, the preventive applications. There is a new guideline that has been set up that was set up by the National Association of Health Insurance Funds. So there is a procedure. The fact that we're somewhat distinguishing between applications that aim at medical treatment, other that focus on prevention, is rather a technical term that probably goes back to I don't know when, but again, there are different procedures, but the address is not BfArM, but the ZPP.
Yeah, we all know the procedure with the ZPP, but I think there's enough room for improvement. And the question is, can we take the good practice of BfArM to take over this kind of process and to modernize the process?
Mm-hmm. I mean, that is certainly an interesting question, because there are new rules that have been put in place, but that's something probably we should discuss about later, because I would certainly be interested what your experience are, and that's probably something for a private conversation we could have later on. Yeah. Mm-hmm.
And to give a fair chance to anyone in the audience, plus the questions that we have on Slido, I would like to continue and try to keep the questions and the answers a bit shorter, so that everyone can have an opportunity.
It's Oliver from Open Regulatory. We help startups solve regulatory problems. So slightly provocative question. Now with the MDR, a lot of software is Class 2A, so that's a much higher barrier to enter the market. And on the other side, I think you have a ton of software which actually is not a medical device, but would deliver like huge benefits to patients. For example, when it comes to patient education or even like preventative care, like we just talked about. So could you imagine expanding the DiGA criteria to actually include software which is not a medical device, so not class 1 and not class 2A?
So first of all, a bit advertisement for your workshop tomorrow. So Oliver is hosting the Open Regulatory workshop tomorrow afternoon. Is it at 2?
It's at 10, actually.
It's at 10 in the morning
yeah.
already, right. Where a large group of people come together who help startups or are working in startups to comply with the MDR regulations. So anyone who has time tomorrow interested in that should join the workshop. Now, to your question, do you want to answer first?
I could probably add one aspect. We're actually doing that when it comes to nursing. We already talked a lot about and extensively about DPAR, and that is one that is probably the procedure where we are trying to deal with software that is not a medical device and trying to answer all these questions that arise if you look at those software. When is it safe? When is it secure? What kind of, or what are appropriate patterns to test the functionality of this kind of software? And I think we've taken a step-by-step approach, and we're seeing what happens there, and if the standards we're setting there can be extended, need to be extended, or should remain limited to that area. So yeah, again, the learning approach.
Hello, my name is Kemal. I'm the co-founder of Shell Sleep. As we all know, healthcare data is so vulnerable and important. So are you planning to work on like distributed ledger systems such as blockchain to store the data?
So I have a very distinct understanding of blockchain as a system that is very safe as long as you control the majority, but as soon as you lose the majority, it's completely unsafe because then someone else has the majority. So I would never recommend to use the traditional blockchain to store any healthcare data, but that is maybe only my personal impression of the blockchain technology for that specific purpose.
I mean, the DiGA-Fast-Track is open to any kind of technology as long as it's a medical device. So
that's true.
If someone comes up with a digital health application that is based on blockchain, it might find its way through. So we just need the use case, actually.
Right. Right.
Yeah, I think there were some questions here in the front. Okay.
Jochen Klucken, University Luxembourg. I have a question to the definition of positive care effects and the benefit. So we just learned this morning this GDPR does not require any benefit definition, it just looks at the risks. The MDR asks us to do a mix of benefit risk assessment. And now the DiGA DVG defines a new certification procedure and also a new definition of benefit. Could you comment on that, if these three aspects in the German system are basically the same or continuum with higher level of evidence, or how does it play together in particular with the MDR and the DiGA?
Well, I can start here. So I think the focus of the DiGA is on the healthcare effect there. So it will be something that will be reimbursed by the statutory health insurances in Germany. So it really needs to show that it has a positive care effect for the people using it. And but for example, a study that will be submitted for an MDR or MDD certificate that can also be possible to show a positive healthcare effect according to the DiGA can be the same. If the requirements are fulfilled according to the DiGA, and I think there's not so much discrepancy there, then the same data can be submitted for both the certificate, CE mark, and also for the DiGA listing.
But for the fast track, you need to be a medical device, and then you still have time to generate this evidence. So it's two types of evidence.
Well, it pretty much depends. So if you're focusing on traditional medical outcomes, and you're conducting trials to prove that you're safe and that you achieve what you claim, you can conduct those trials at once or at the same time. It's a theoretical possibility if the requirements according to the MDR are completely the same that are set up by the DiGA. Pretty much depends on the individual application at hand. So I mean, the BfArM is pretty open to give advice at every stage of the development of your product. So if you're, if you're just developed your software, and you're thinking about conducting trials in accordance with the medical device regulation, and you think, why shouldn't I consider the evidence that is needed for the BfArM fast track at the same time? The obvious advice would be go to the innovation office of BfArM and see if these two set of rules can somewhat be aligned and spare you costs and time effectively.
Let's have 2 more questions from here, and then a few from the audience from the live stream, and then we'll go back to the questions here in the room.
Thank you. Hi, I'm Jörg, professor and program head of digital health at Deggendorf University, south of Germany. A question is also regarding research. Is there anything like a centralized framework to coordinate, to advance, or to support research on DiGAs? Anything like that being considered a centralized framework? Or do you think companies are better off organizing research on their own? And in a wider sense, what do you think should be the role of academia in this DiGA ecosystem? Thank you.
Maybe I start and then you add on. So far, to my understanding, we don't have that because simply it's a completely new world, and we have puzzle pieces in various scientific areas and also in various geographical areas. For example, in the United States, research on digital applications as such is far more progressed, and they are far more open to new forms of evidence designs than we are here, especially in Germany, but also in Europe. And this is why tomorrow we have the Evidence Con to bridge those two also scientific or academic communities closer together. The Americans are very interested in what's happening here because they don't really have use cases. They have now all the evidence designs and first research going on, but the healthcare system as such is still somewhat closed. They are lagging behind, exactly. So this is an interesting point of time where we have the components but not yet in the right mix. Ideally, we are going to develop a framework out of that, and that would be the role of academia and research to make sure that we know the new boundaries that we are working within. We don't have them yet. This is why everyone is now going to RCTs, because that's the safe bet. But in my understanding, having an RCT, a very rigid structure for a completely agile, dynamic product that is also adapting over a few months in the patient's daily life, that does not fit. So we would need an evolution, but so far we are still in the exploring mode. And one challenge, and to be honest here as well, is for price negotiation, you are not negotiating with a group of experts that is very open to something else than RCTs at the moment. So this is why, in my understanding, everyone is going for RCTs right now to be on the safe side, although it certainly has limitations and it was never made for digital applications. Exactly. One last question, and then we go to Slido and then back in the room.
Kurt Höller, Director of Business Creation at EIT Health. I've been part of the Health Tech Innovation Days when Macron announced that he would replicate the German DiGA system. Now my question would be, would you recommend him and his authorities to accept evidence shown by any startup in Germany already for their application in the French system once a French system is in place? So if any company, if any startup has already shown evidence to the German authorities, should the French authorities then just accept it, and vice versa? Would you in Germany also accept that proof of evidence if it is already validated in the French system? Because that, of course, would be much more powerful if you would have an international system where you would not have to go from one country to another one to get approval for the evidence.
So how do you deal right now if the evidence is coming from France, for example?
So if I already answered it a few questions ago, so if the care setting or the setting is comparative to the German setting, then I think it would be easier to all of us to accept these data. We would not ask to replicate these in Germany again. But again, as I said, it needs to show, or it has to be proven that the standard of care setting in Germany is for this setting the same like it was in France. Then it would be acceptable. And I think also vice versa. If France will adopt the system one-to-one, then it will have the same requirements also regarding the evidence. And I think then they will also accept these kind of evidence.
And that is precisely the question we will have in the panel in 2 hours from now. What are the standards that we set? In which framework do we agree on the same evidence, or can we harmonize at least the requirements to that extent? So that's exactly why we have all the European nations later on here on stage, to not define but to start the discussion on in which evidence environment do we want to work. And I would imagine that especially smaller countries would probably be even happy if they don't have to do the entirety of the work on themselves, but can rely on other nations who have already pre-qualified, for example, if you would apply the DiGA-Fast-Track, such DiGA evidence. I would quickly go now to the questions on slide, because there were a few ones which we can answer easily, and others that I want to discuss with you on stage. First, are medical guidelines in Germany already recommending the usage of DiGAs? To my knowledge, not yet, but, and that's the good news, and that is highlighting on the point that I did early on, more and more of the scientific societies in the background who define those medical regulations are in heavy exchange or intense exchange with DiGA manufacturers, and are now also more and more understanding their role, that they support the DiGAs that hit exactly their needs. So we are not anymore in a situation where the DiGA manufacturer world is completely separated from medical practice, but medical practice is more and more understanding that they right now can co-create the solutions they will need anyways, or they aspire to have. And this is a great change also in the mindset of the medical societies. So I expect to have DiGA being recommended in the medical regulations in the next 1 to 2 years. Maybe more questions to my colleagues here on stage. One question directly to Dr. Hunze. Are there any considerations to allow the use and reimbursement of DiGA in the inpatient sector in the future? Stichwort intersektorale Versorgung. In other words, how does the BMG plans to overcome the limitations in intersectoral care?
I mean, there's already legislation that allows hospitals to prescribe DiGAs once a patient is released, set out into the free world when he leaves hospital. There is still a piece of agreement necessary between the National Association of healthcare funds and the hospital society, and we are looking pretty much we're looking forward that this piece of or that this agreement will be there soon. So that is what we are focusing upon at the moment. If there will be applications that focus on hospitals mainly, or if DiGAs will be used in hospitals in a more regular manner, is a question that still needs to be answered, and we have no answer here yet on a definite frame.
One question to Wiebke. When will a new DiGA guideline from BfArM be published? The last version is from October last year, so are there any current plans?
Yes, I think there are the last work, or there's currently the last work on the update going on, and it will be published in the next days.
Perfect. That's great to hear. I would say we have one last question from the audience. Who has a pressing question that should be answered right now? I see one hand there, and one hand in the very back, even two hands. Let's have very short questions and then very short answers, and then you're all free to go to the coffee break. Where will we start? Over there.
Hi, my name is Beth Wolf. I'm from a Danish app manufacturer, and I just wanted to follow up on the comment you made about the DiPA, because I was a little confused about that. As we understand it, we're waiting for a DiPA set of regulations to be released. Is that correct? Is this okay? Do you have any idea when that will be?
Well, again, it's what somewhat makes it unpredictable is the fact that we are still waiting for a new government to be sworn in. But the overall idea is, well, we haven't stopped working at the moment. The overall idea is to set up a draft, internal one, until like Christmas probably. And once we have a new government and a new year, probably one is a bit earlier than the other one. We're hoping that we can draft it at the beginning of next year. But again, it pretty much depends if the parties that are negotiating the coalition agreement will form a new government, because it's somewhat of a constitutional convention that you don't publish far-reaching pieces of either legislation or regulations in the period when you have just an acting government. That is somewhat what is somewhat preventing us from going forward faster at the moment.
Next question over there.
Yes, thank you. My name is Margot. I'm one of the co-founders of Mediwell, and I had a question regarding how the patients would receive the DiGAs in the future. So right now, you're very dependent whether or not your doctor knows the DiGA or wants to prescribe digital solutions. Are there any steps in the future that you want to make for a more holistic, more easy approach for patients to receive DiGAs and the care that they actually need? Because DiGAs have to show that they have a positive effect, so that means they would be beneficial for the patient, but it depends whether or not the doctor would prescribe it to you or not.
There actually is another way at the moment. What we are seeing is that, of course, that whenever patients have a disease, they go to their doctor because this is the one who they are relying on. But if the doctor is not willing to prescribe a DiGA, and it is medically necessary, of course, there is another way. The patient would then have to go to its health insurance fund and ask if he's entitled, has to prove a medical indication. If he can prove that, the prescription is not necessarily the health insurance fund will grant will send an access code without the need of a medical of a prescription by a physician.
There was one last question which we're going to answer, and then we go for the break.
Yeah.
Perfect.
So my question was mostly about the future of the DiGA process. So where do you see it in 5 years? Meaning that I think the DiGA application started a year ago and we already have 24 DiGA that are admitted and reimbursed. What about next year? Is it going to be 50? And do you see a limited number of reimbursed application in the long term once all the, well, or most of the pathologies are covered?
Ladies first.
It's a good question, and I have no concrete answer for you, but what I can say is that we see a stable number of people asking for advice by BfArM, and I think if what we heard is that they are planning to submit soon. So I think we will see a growing number, but what exactly it will look like, I cannot say at the moment. But I think it's a starting point, and I think 24 within 1 year is a good number, is a good start. So let's look into the future.
Yeah. I would probably just like to add one point. I think it's not only about numbers. What we've seen at the moment is that we are covering, or that there is a huge focus on psychotherapy. I think what would be important for us is to cover more diseases, to have a greater variety of diseases that are covered by the offer that we are making to the patients, and that the variety grows, and that's not necessarily. Of course, the numbers need to grow to achieve that goal, but I think numbers aren't everything.
And I would argue in 5 years from now, it doesn't matter if you are in inpatient care, outpatient care, if it's a disease that is very common or a rare disease. It's completely normal to have digital solutions that are prescribed to you, and also the healthcare system is very much accustomed to that, and they also used to get your data into their health records and vice versa. So I do hope that we get to this future where it's just normal to have digital solutions, as it's normal nowadays to have medicine. Let's maybe close with that, because we are very much over time. I want to thank my interview partners here for their bravery to go to the Ask Me Anything session, Wiebke, Löbker, Lars, Hunze, and we see us soon at 4 p.m. then for the European afternoon of this conference. Thank you very much.